joining us. I know we're letting in people from the waiting room. So welcome to everyone who's just joined us from the waiting room. We are going to be starting in about 3 minutes. So this will give you a chance to make sure that you can hear us. If you've just entered, we are going to be having you on mute when you enter. And so if you do have any questions for us, please feel free to use the chat function. We are monitoring the chat. So if you're either having a technical issue or a content issue, certainly please let us know. And if you have any questions for the speakers or for any of us, you can enter those right into the chat. We're really delighted that you could join us today. And I'm just going to keep talking so that you can check your sound, so that you know you haven't entered an empty room here. So we're so happy. I know we have registrants from 350 people registered for our symposium today, really truly from around the globe. And we're delighted that we're going to be able to present 19 different speakers to you from 11 different countries. So truly an international effort. And we appreciate that people are able to reach us from across many different time zones today. So we're delighted that you're all here. And as I mentioned, we'll be starting in about 2 minutes. So for the moment, I'm just chatting and welcoming you to our group. You'll see a few familiar faces here on video. We have Sidra Khan, who's the chair of our trainee committee. It's waving at you there. And you'll see Wingfield Remus, who's our secretary treasurer. You'll see Claire Fuller, who's our vice chair. And then you'll see all of our speakers. We also have Joe Groves from the International League of Dermatologic Societies. And I see that several members of our steering committee and advisory board, such as Colette Van Hees, have joined us as well. So we're really delighted to have all of you with us today and joining from so many different places. Great, so I love seeing people use the chat function, so we know that it's up and working. As I mentioned, if you've just joined us, we will be monitoring the chat for any questions for the speakers. And also any technical issues, feel free to put your technical issues in the chat and we'll do our best to resolve them. I'm just going to keep chatting so that anyone who's just joined our program can just check their sound and make sure that they can hear us. I think we'll be starting in probably just a few seconds here. I think we've just hit the top of the hour, so I'm going to give just a minute for everyone who's in the waiting room to join us. And then we'll get started. So, as I mentioned before, we're just so excited that we have a great group of 17 different speakers from 11 different countries and so many different folks from truly around the world joining us today. It's really just an honor to be here and have all of you. And I wish this was in person, but I'm sure all of us would love to be in Vienna, which is where this meeting was supposed to take place, but instead greeting you from my office in my house. So great. And hello to everyone who's telling us in the chat where you're joining us from. I think it's wonderful to get a sense of where people are coming from. So if you're able to, please put in the chat where you're joining us from, so all of our attendees can get a sense of where everyone is from. Wonderful. All right, well, I think we're 1 minute past the hour, so I'm going to get started. And I know that people are going to continue to filter in and to join us. So I'm watching our numbers rise, but I will get started just to keep us on time. So I'm your MC for the day. We are absolutely delighted to welcome you to the GLODERM Virtual Scientific Symposium, which is being held as a pre-EADV meeting. As I said, we were meant to be in Vienna, but we're absolutely delighted to have you here virtually. Can I have the next slide, please? So just a few quick Zoom meeting tips. So when you come in, you'll be automatically muted just to minimize kind of distraction and background noise. If you do need to slip away for a while, we would recommend that you don't leave the meeting. We would just recommend that you can turn off your video and step away. Sometimes we found that if you leave, the meeting does not allow re-entry, or it makes it a little bit difficult to re-enter. So I would encourage you just to stay in the meeting and step away if you need either a bio break or some water. And we will have time in the agenda partway through for a quick break. We would love to hear from you. We really encourage participation. So you can use the chat feature to get in touch with us and to also get in touch with the speakers. And we do have both Wingfield Remus and Claire Fuller will be managing the chat and telling the speakers about any questions that you might have. We will have time for Q&A at the end of each session. And so please feel free to, again, hit the chat button. It should be potentially on the lower part of your screen. The chat button looks kind of like a little word bubble. And right now you can put right in it where you're joining us from. Next slide. We will ask that halfway through the meeting, right before our break in the middle, we're going to ask that everyone who's able to can please turn on their cameras and we'll do a quick group shot. This is our group shot that we captured at our last virtual meeting at the AAD. This was thrown together very quickly when none of us had used Zoom yet. So I think we're all a little bit better at it this time. So this is our quick attempt last time, but we will be capturing group photo and it may just take a few seconds because we'll run through a couple different pages. Next slide. This is our agenda this morning. I'm so excited for all of our wonderful speakers. And as you see, we're in our welcome right now, and I'll introduce the next speaker at the end of this session. You'll see partway through at 15:50, we will have a Q&A, which can also be used as a small bio break if you need it, and that's when we'll do the group photo. Next slide, please. So I'm really delighted to welcome you today, and I thought I would just give you a quick couple of minutes on our history of GLODERM and where we're headed to from here. Next slide. So we've really grown very rapidly, and I'm delighted that so many of our steering committee members and advisory board members are on the call today. We actually only formed back in 2018 as a steering committee. And then we had our first annual meeting in 2019. We had our first virtual meeting this March, which was really right. The American Academy of Dermatology ended up going virtual only a couple of weeks before the actual meeting. And so we very quick turnaround and had our first virtual meeting. I'm delighted to say that our trainee committee, which we'll be hearing more from in a moment, was also formed this past spring and summer. Here we are today at our first ever EADV pre-meeting, and we're so excited to have so many wonderful speakers. And in terms of what we have on the horizon, we have our monthly global trainee committee webinars, which are really well attended at the American Academy of Dermatology this spring, which may be virtual. We'll be having another meeting, and then we're already excited to say that we'll be at the International Congress of Dermatology in Melbourne 2021, which we will all see where we are come next November, but hopefully in person. We currently have over 450 members truly from around the globe. Next slide. Next slide, please. Perfect. Yeah, thanks. So I just wanted to share a map with you. And actually, just a quick note, Sarah, or whoever's running our slides, so we do seem to have a red line across most of the slides, which doesn't bother me, but might be in the way of some of our speakers' stuff. I'm not sure if it's possible to remove that part. So in terms of where our speakers and our members are coming from, this is a survey that we did after the last American Academy of Dermatology meeting for GLODERM. And I'll just chat through just fixing some technical issue there. So basically our members come from all around the world and really do research and do clinical care truly all around the world as well. So while we're just fixing that small technical issue, oh, that's perfect, thank you. That's great, you can go to the next slide. Thank you, Safia. That's perfect. So our moniker is Skin Health for Everyone, Everywhere. And this is our vision statement. And I would just like to say a little background of kind of who we are. So the International Alliance for Global Health Dermatology, known as GLODERM, is an alliance of professionals, trainees, and other concerned individuals really to advance skincare provision, especially for patients in low resource settings. And GLODERM's aim is to provide a community of individuals focused on global health dermatology who will provide expertise to international agencies such as the World Health Organization, share best practice, pool technical know-how, and especially support our trainees who are interested in pursuing a career and interests in global health dermatology. Next slide. And so a big thank you to our steering and advisory committee, many of whom are on the call today. Next slide. And also a huge thank you to the International Foundation for Dermatology, which is the arm that's carrying out the global health dermatology work of the International League of Dermatologic Societies, who supports projects in Africa, Asia, Pacific, and South America through a number of different programs, including the Regional Dermatology Training Center, which we'll be hearing representatives from shortly. And they're supporting and helping with the logistics around GLODERM, and we're so appreciative for their involvement. Next slide. So we do have a social media handle. Our hashtag is GLODERM2020. And you can also tag us at GLODERM Alliance, both on Instagram and on Twitter. So please feel free to tweet and to post about the meeting as it's going on. We'd be delighted to hear from you through social media. Next slide. And so I'm delighted with that to introduce our first speakers. So I'd like to introduce Sidra Khan, who's going to be talking about the GLODERM Training Committee. And for the first time, we have officially some of our trainees that are giving presentations. So we're so excited. This is the future of global health dermatology right here with our trainees. So Sidra Khan studied at the University of St. Andrews in Scotland and the University of Manchester in the UK before undertaking her medical training in Scotland. And she now works as a dermatology trainee at the Dermatology Centre in Salford Royal Hospital in Manchester. And importantly, from our perspective, she is the founder and current chair of the GLODERM Trainee Committee, and she's part of the IFD's Migrant Health Dermatology Working Group. So with that, Sidra, I will turn it over to you.
Oh, hi. So we have recorded our talks, but we'll start that now. Thank you.
Sarah, or we're not actually hearing anything, I think, on our end.
You might just need to unmute yourselves.
Yes, sorry. Let me just unmute myself.
I'm currently a dermatology trainee in Manchester in the UK. Hi everyone, my name is Sidra and I am currently a dermatology trainee in Manchester in the UK. I'm also the current chair of the GLODERM Trainee Committee, and today I'm going to give you a very brief introduction into our group and what we're about, and then hand it over to some very talented dermatology trainees from around the globe that are going to be showcasing some of the work that they're currently doing. So who are the GLODERM Trainee Committee? Well, we're a group of trainees and specialists that came together with a shared vision and goal.
Oh, we lost our sound again.
Sorry, I was muted for some weird reason.
Networks and collaborate. By improving educational opportunities for trainees, we hope to empower future generations of leaders in the field of dermatology from around the world. So although our group had been in communication for some time with ideas about this initiative, it really wasn't until the height of the current COVID-19 pandemic that we put our plans into action. A number of us were experiencing very similar disruptions to training, whether it be reduced patient contact, complete cancellation of educational events and meetings, or redeployment. At the same time, a number of us identified that there were many opportunities that did not previously exist. For instance, there was a huge influx of teleconferencing software that was being made widely available and at a very low cost. And there was certainly a need to fill the gap in dermatology education and training. So our group felt that perhaps now more than ever was the opportune time to launch our initiative. And so we did. So at present, we are running 10 once-monthly Zoom webinars. These are being delivered by experts in the field from around the globe. We have strongly encouraged all of our specialists to involve their trainees as much as possible in these webinars. And this is really to give them a platform to present at an international meeting. We are also building a bank of free online educational resources. And this really relates back to our point about improving access to educational materials. Hi, everyone. My name is that they're currently doing.
Sorry, it's good. Apologies.
So who are the GLODERM Trainee Committee? Well, we're a group that works and collaborate. Contact, complete cancellation of education. And there were certainly monthly Zoom webinars. These are being delivered by experts in the field from around the globe. We have strongly encouraged all of our specialists to involve their trainees as much as possible in these webinars. And this is really to give them a platform to present at an international meeting. We are also building a bank of free online educational resources. And this really relates back to our point about improving access to educational materials. For instance, trainees in certain regions may not have the best cellular connectivity and be able to participate in live events. There's also the issue of time zone. So we're hoping that being able to provide this bank will tackle some of these issues. We are also in the process of conducting a qualitative questionnaire, looking to explore the needs of participants and evaluate the impact of a global virtual teaching program. So we actually had our first event in September, and this was a talk on hair disorders by Professor Narcosa Delova and her resident Dr. Rafense Toby from Durban, South Africa. Despite a few technical difficulties at the start, the event was a success. We had 88 attendees from 5 different continents, and the feedback was generally very positive. So I've spoken a little bit about what we're currently up to, and I just want to mention some of our future plans. Looking ahead, we want to be able to increase the number and variety of online teaching events, for instance, providing journal clubs. Along with our parent organization, GLODERM, we want to work together to build a mentorship platform. And we want to continue to build our bank of free online resources for trainees. Looking further down the line, we're hoping that this initiative can create opportunities for trainees to collaborate across centers on projects, but also facilitate exchange programs and international fellowships. Thank you everybody for your time. And now I'm going to hand it over to our next set of speakers, Akash and Dorian, who are going to be presenting some data that they've been analyzing from the RDTC.
Hello everyone, thank you so much, Sidra. My name is Akash Varma, and I'm currently a 4th year medical student at SUNY Downstate Health Sciences University in Brooklyn, New York.
Hi, my name is Dorian Sabushiniki. I'm from Burundi. I'm a dermatology trainee at the Regional Dermatology Training Tanzania.
And we're going to be presenting on the range of distances and presentations of patients attending the Regional Dermatology Training Center in Moshi, Tanzania.
The Regional Dermatology Training Center in Moshi, in Tanzania, was founded in 1990 as a joint effort between ILDS, the Ministry of Health of Tanzania, the Kilimanjaro Christian Medical Center, on a land provided by the Good Samaritan Foundation. It was created with an objective of prevention, treatment, and rehabilitation of skin diseases, leprosy, and sexually transmitted infections in the sub-Saharan Africa through training of appropriate health workers.
So the Regional Dermatology Training Center has been recording diagnosis, demographic, and treatment data from its patients starting in April 2017. Taking a look at this data, which included 45,000 entries, we took 10% of these, which met our inclusion criteria of having the full demographic information filled out and fully coherent entries, to analyze how far patients were traveling to receive dermatologic care by simplifying their addresses as belonging to one of the 31 regions of Tanzania, and what diagnoses they were presenting with by translating these to their corresponding ICD-11 classification.
So this is a slide showing the map of Tanzania and the neighboring country, Kenya. It shows the different regions of Tanzania and the islands. So we have patients coming from all these regions. So the RDTC is located in the Kilimanjaro region. Which is in white, and as we go far from Kilimanjaro, the color of the other region goes darker. The following slide is showing numbers of patients traveling from each region coming to RDTC in Kilimanjaro. So as expected, we have a bigger number of patients coming from the region of Kilimanjaro is located RDTC. We have more than 3,000 patients, followed by the neighboring regions, Arusha and Manyara. Surprisingly, we have also a big number of patients coming from the region of Dar es Salaam, which is the economical capital of Tanzania, and where we have a big number of dermatologists. So we have patients coming from all these regions, even those coming from the forest like Ruvuma, Mtwara, and patients coming also from Kenya. The following slide is showing, it's a figure showing distribution of patients and business travelers. As I said, we have a big number of patients coming from the region of Kilimanjaro is located RDTC. And as we go far from Kilimanjaro, the patients goes decreasing in number, but still we have patients coming from the farthest regions, like from there to Ruvuma. Those are regions where patients have to travel up to 2 to 3 days coming by transport, public transport.
So now that we understand how far patients are traveling to receive dermatologic care, we can evaluate what they're presenting with. The greatest category is inflammatory disorders, followed by infections and infestations, and then skin disorders involving specific cutaneous structures, namely hair follicle, as well as skin disorders provoked by external factors, which mainly includes photodermatitis and allergic dermatitis. There's also a wide variety of other dermatoses seen listed on the side, which we won't delve into in this presentation. Looking into the inflammatory disorders more closely, 80% of these are dermatitis and eczema, followed by a much smaller second majority of papulosquamous disorders, including psoriasis, which only account for about 9% of these inflammatory disorders, indicating a great burden of dermatitis and eczema in sub-Saharan Africa. In terms of infections and infestations, the large majority is mycoses or fungal infections, followed by bacterial and parasitic infections, which together make up a quarter of the remaining presentations. And then viral and sexually transmitted infections make up the rest. Now, if we examine the patients that are traveling over 1,000 kilometers or from the neighboring country of Kenya to the RDTC, we see that once again, dermatitis and dermatophytosis are the most common conditions seen, followed by keloids. Keloids are interesting because the RDTC can only provide treatment if patients are able to come for multiple visits, which these patients are often unable to do, and unfortunately have to be turned away without receiving treatment, even though they've traveled far distances. Thus, as we can see, there's a wide variety of dermatoses encountered at the RDTC, and patients are willing to travel far distances to have these evaluated and treated. This suggests that in the future, there is an increased need for access to dermatologic care in the peripheries of Tanzania, which can be accomplished through teledermatology services, training programs for physicians in remote areas in dermatology, either virtually or in person, as well as outreach programs led by the RDTC to provide dermatologic care to these remote regions and individuals who are unable to travel to the RDTC. We'd like to acknowledge the following individuals. Thank you so much for your time.
Thank you, Akash and Dorian. And now we're going to hand it over to Tuta from Yangon, who's going to present a recent clinical case that he was seeing.
Thank you, Sidra. Hi, everyone. I am Tuta Tezin. I'm a third year postgraduate dermatological trainee from University of Medicine to Yangon. Today, I would like to present an interesting case on behalf of our Professor Dr. Myasanda Jo and Dermatological Department, University of Medicine to Yangon. 25-year-old single lady came to our department with a chief complaint of assaults on the secret node due to trauma for about 2 weeks. She also has another complaint. There were swellings on the ascensor surfaces of the extremities, buttocks, sacral areas, and right ear for about 20 years. She first noticed a small swelling on her left elbow at 5 years of her age. It gradually increased in size, and then similar lesions appeared on the ascensor aspects of the upper and lower limbs, buttocks, sacral areas, right ears, as you can see in the photos. These swellings are usually asymptomatic, but this condition does give her problems, cosmetic problems, since they were on the pressure areas. The nodules were easily traumatized. She has difficulties in sitting and wearing sandals. Then on examinations, there were multiple well-defined flesh color nodules on the right ear, elbows, and knees, ankles, feet, sacrum, and buttocks. They are varying sizes ranging from about 10 to 9 centimeter in diameter and 3 into 3 centimeter in diameter. On palpations, the nodules were firm, they are freely mobile, not attached to the underlying muscles, they were not tender, or the temperatures on the nodules were similar with their surrounding skins. And then you can see there were 2 ulcers on the nodules, which was present on the sacral areas. They were about 20 to 1 centimeter and 1 to 1 centimeter in diameter. After history-taking and clinical examinations, we consider these possibilities: tuberosantoma, chondroma, rheumatoid nodules, gouty arthritis, neurofibromatosis, and calcinosis. And then we'll proceed to the investigations to get a diagnosis. She had hyperchromic microcytic anemia, but her iron study was normal. Her lipid profiles and her liquefaction tests were normal. Rheumatoid fever was not raised, or her serum calcium phosphate and uric acid were also within normal limits. There were no significant abnormalities in serum protein electrophoresis and reflection tests. So we also performed imaging studies. Ultrasound on the limb showed that there was a misechogenic lesion with internal calcifications and soft tissue swellings. On the abdomen and pelvis, the ultrasound result was showed that there were no abnormal findings. The Doppler ultrasounds on the lower limbs they showed that there were no other images. We also performed X-rays on the pelvis, hands, and feet. The result was the results were only rounded soft tissue opacities with no obvious bone lesions. We also took a biopsy from her nodules. The result was compatible with xanthoma. So in summary, she had asymptomatic generalized nodules, especially on the extensor surfaces. She does not have any eventful family histories and no obvious underlying diseases. Her lipid profile was normal, but the histopathology results of their nodules was compatible with xanthoma. So we arrived to the diagnosis with normal lipid multiple large tuber xanthoma. After the diagnosis, she was treated with surgery, and then we also give her lipid-lowering agents like statins. Thank you for your attention.
Great, what a wonderful case. Thank you to our trainees, and we're just so delighted that we're able to have trainees giving talks, and clearly we need to keep this up in terms of our trainees are just giving really wonderful, wonderful information. What we're going to do is please do put any questions in the chat. We're probably going to hold questions on this section to the general Q&A at 10 minutes to the hour, only because one of our later speakers has a strict time deadline. So we're going to try our best to stay on time for the moment. And so please do put questions in the chat, and we will get to them at the general Q&A and a few speakers from now. But we really appreciate our trainees giving such wonderful talks today. Next up, I would like to introduce Dr. Loria Bajazhoitia, who will be joining us today. She's a dermatologist in Madrid and did her PhD on prevention of skin cancer and photodynamic therapy. She participated in dermatology workshops for African dermatologists in Tanzania from 2008 to 2017. And since then, she co-founded Beyond Suncare with Mafalda Soto, which is an NGO focused on the care of persons with albinism in Africa. And she shared her knowledge about dermatology and albinism in her blog called Blog de Dermatología since 2013. And with that, I will pass it over.
Hello. Good afternoon to everyone. Thank you for the invitation to share our experience with the NGO Beyond Suncare. The title of the talk is Progress on Improving Outcomes in Persons with Albinism in Low and Middle Income Countries. Can I have the next slide, please? I guess you are all aware of the situation of persons with albinism in Africa, but to summarize, there are more than 200,000 people living with this condition in Africa. More than 600 of them have already got attacks, and more than 200 have been killed so far. However, this is the most mediatic part of the issue, but us as dermatologists, we do know that the great problem that they face in their everyday life is skin cancer. 90% of persons with albinism in Africa have a life expectancy shorter than 30 years old. And that's due to skin cancer. Next slide, please. You know that actinic keratosis are the precursors of skin cancer. Most of people with albinism, they do get AKs at the age of 8, and all of them get them by the age of 20. Turn into squamous cell carcinoma, and some of them do get as big and as terrible, let's say, as the one you see in the picture, which of course has a poor prognosis. Can I have the next slide, please? So I've experienced this since 2008 until 2016. As Esther already said, I was forming part of the workshops organized by my colleagues from Ramón y Cajal Hospital in Madrid. We usually, next slide, we visited RDTC every year, and we organized lectures on skin cancer. Next slide, please. Practical workshops focused on different types of sutures, stitches, grafts, flaps. Next slide, please. And many surgeries were performed during our stay of skin cancers of people with albinism. At the very beginning of the project, it was us mostly who operated, but at the end of it, they were the local dermatologists who performed the surgery. So this had made that nowadays RDTC is one of the referral centers for skin cancer in sub-Saharan Africa, and that's, I mean, I'm quite proud of having been part of this thing. Can I have the next slide, please? During my visits to RDTC since 2011, I got the chance to know Mafalda. She's also from Spain, and she came to RDTC to Tanzania to start a very beautiful project in the context of the very well-known albino outreach project of RDTC, which was running since the 90s. She developed this sunscreen project, locally produced sunscreen for persons with albinism, which was distributed in Kilimanjaro area. Next slide, please. So this started as a small production in a small container, and in 2011 it became a proper building called Care Unit for Persons with Albinism, and it covered around 2,000 persons with albinism who got their sunscreen twice a year at least. Next slide, please. This is an image of the sunscreens produced. Next slide, please. So producing a proper sunscreen, of course, has a lot of technical issues, which I cannot explain you because I'm not aware of them, pharmaceutical issues, but studies show that the most important aspect indeed is the lack of compliance, and that's the key point in Africa, and that's why Beyond Suncare, our NGO, is focused on these 4 aspects you can see here, which we call the Beyond Protection Packet. It includes production, education, distribution, and monitoring. So Beyond Suncare was born in 2017 with the aim of crossing borders and improving the lives of thousands of persons with albinism, expanding the project that was already created in Tanzania to other neighbor countries. Next slide, please. The production ideally should be local and, of course, a customized sunscreen according to the preferences of the beneficiaries. Next slide, please. Sorry. Education is also always a a key point together with the distribution of the cream. And education is important both to beneficiaries but also to health providers. Capacity building of health providers which are not that used to a white skin and albino skin is also very important in this context. Next slide, please. We try that the distribution is decentralized and free in all our projects. And next slide, please. And monitoring, of course, we think it's necessary. Following up the beneficiaries from a clinical point of view, always together with local dermatologists, local clinical offices, and of course, measuring the impact of the program. So Beyond Suncare was launched in 2017. It was declared best practice by the UN since then, and we have already 4,000 beneficiaries. Half of them are children. We are working in 5 countries, and the cream has shown to decrease in 70% of cases the number of AK on the signs of skin cancer. Moreover, the beneficiaries declare that their self-esteem has increased once after entering the program. Next slide, please. So just I want to share with you the steps followed in the last years. In 2019, the management of the KSPU in Moshi was handed over to our Tanzanian colleagues. In the same day, we launched a specific new formula for the sunscreen, and this was called Umotsi Max because it was prepared especially for Malawi. And we launched this formula in Malawi at the beginning of 2019. I'm sorry about this, Imanol, por favor, ¿vale? Next slide, please. So I just want to share with you the results. First, I'm sorry, mira, hijo, esto es no puede ser. This project was run from February 19th to April 19th, and it was run in 2,000 beneficiaries. Half of them were male, half of them were female. Next slide, please. In terms of the educative intervention, it showed that it enhanced the use of all photoprotection measures, it decreased the incidence of erythema and actinic keratosis, it improved the knowledge about condition and how to manage it, and it was very well accepted by the beneficiaries. So it has a positive psychological impact. Next slide, please. And regarding the cream, the sunscreen itself, it was developed especially for sub-Saharan persons with albinism. It was very well accepted. It was effective in the short terms in terms of AKs and sun damage signs, and it showed good tolerance. Next slide, please. So our plans for this year, we've expanded this pilot project and we launched it in 7 districts in central Malawi. We are preparing some projects in other African countries, and nowadays we have around 5,000 direct beneficiaries. Next slide, please. Next slide, please. So we are at this point now. No, the previous one, please. The one with the red circle. Can I have the previous one, please? Yeah. This is where we are currently now, the setting where we are in 2020 with the pilot study running in 7 districts. This covers around 1,000 beneficiaries. And next slide. And the aim is to expand this and to upgrade it to a national level in Malawi, hopefully next year or maybe the year after. And trying to build a local sunscreen production unit in the same way it was done in Tanzania. So export the model that worked in Tanzania at RTC to this country. So, and hopefully that will cover around 9,000 direct beneficiaries. Next slide, please. This slide is just to introduce to you the whole team and our advisory board. We are so thankful to all these persons here. Claire is around us today. And next slide, please. both the advisory board and the partners are not only from the dermatology and cosmetic world, but also for the human rights organizations and also local organizations which we think is a key point in the development of our projects. So thank you for your time, and you have my email down there in case you have any further questions when the meeting is over. Thank you so much.
Thank you so much. What an incredible talk and so fascinating. And I also want to say we're triply impressed because I think it's so important for our trainees to see what it's like to be a working parent. So we're very you're, I think, living the real life, and I think it's a wonderful example for our trainees that are attending as well, managing that.
Okay, this was not planned, but I mean, that, so I'm so sorry about that.
It's really impressive nonetheless. So yeah, if you're okay with that, Dr. Bahathwaite, which we're going to do is we're going to move on to our next two speakers. I do want people, I think people have some really great questions for you, and it was such a great presentation, only because we have a time pressure on one of our little later speakers. But at around the top of the hour, we will have time if you're able to stick around for Q&A just in a couple of minutes from now. Thanks so much.
I will stay around. Thank you so much.
Perfect. Your Q&A a little bit later. Thank you so much. So next, I'd like to introduce Dr. Esther Nzumara. And besides having a fabulous first name, of course, we're absolutely delighted that she's joining us today. And she's joining us from the Regional Dermatology Training Center she was trained in the Regional Dermatology Training Center in Tanzania. She's one of 2 dermatologists in Malawi and is the head of the dermatology department at Kumuzu Central Hospital in Lilongwe. She has been a board member for Beyond Suncare, which we've just heard about in Malawi since 2000. And she also has a certificate with the American Academy of Dermatology and volunteers in supporting the Regional Health Bureau and the Federal Ministry of Health, technically in NTD management. And she also leads the emergency response for scabies and works in the advisory committee for the Ministry of Health. And we're absolutely delighted to have her with us today.
Apologies, I will play.
Thank you so much. Can you hear me?
Yes, we can hear you. Thank you.
Okay. As just already said, I'm Dr. Tengana Nzumara, and I would like to thank you so much for giving me this opportunity to present on support for persons with albinism in Malawi. Can I have the next slide?
Give us 1 second on our technical issues here.
I'm having slight technical issues, sorry.
Okay, next slide.
Good afternoon. I am Dr. Tengana Nzumara, and I'd like to thank you so much for giving me this opportunity to present on support for persons with albinism. So basically, I'll just talk about the challenges that they go through, the main ones, and also the organizational support. So Malawi has a population of 18 million, and according to the population and housing census, we have 135,000 persons with albinism in Malawi. But there are lots of challenges on albinism. The main one is lack of knowledge. There are many myths that surround albinism, and these myths are not only in the people who have albinism themselves. The lack of knowledge is also in the general population. And because of this, we do have so many consequences because of this lack of knowledge. One of them is presenting with advanced tumors, as you can see with that lady who has just been discovered on one of the clinics last month. The health system also has a challenge. Persons with albinism can go to the nearest clinic, but there, most of the times, they meet a person who doesn't know their condition, so who cannot manage their skin, who cannot even recognize the cancer in early stages. That is just showing a picture of a boy who I saw in 2014. He had a small tumor, but it was very close to the eye, so I couldn't operate him, and I referred him to the surgeons and ophthalmologist, but he kept on being sent back, and the tumor was just growing. So I said, okay, we're gonna take a risk, and I operated him, but I told him that we have left some tumor. I'm very sure I've left tumor because it's very close to the eye. So I did a graft
He was so happy for about 6 months, but then it started growing back, and it's now like that, as you can see, since 2014. The other challenge is with safety because of the physical violence, the killings that were there in the, recently. Most people are afraid to come in the public. We were doing a training for primary school teachers, teaching them on what albinism is, so that they can be teaching it to their students. But we noticed one thing, that children with albinism had stopped attending school because they were very afraid. So we have several programs or organizations that are supporting persons with albinism in Malawi. Of course, the government, we have Beyond Suncare, Standing Voice, as well as Tumaini. The government has included sunscreen to be part of the essential medicines since 2015. Before that, it was not part of the essential drug list. Persons with albinism have an association. They are assisted. It's called APAM, which is Associations of Persons with Albinism in Malawi. And this organization is under FIDOMA, which is the Federation of Disabilities Organization in Malawi. There are DVOs, that's dermatovenerology officers in districts in Malawi, where government has at least made sure that there's a DVO in every district so that they can see persons with albinism in these districts. Also, we have 3 central hospitals, and in these central hospitals, we do have, of course, dermatologists, plastic surgeons, oncologists, as well as ophthalmologists. So one of the organizations that's helping us is Beyond Suncare. Beyond Suncare, we are doing a national program in Malawi to ensure that there is access to high quality sun protective services. So we focus on 3 areas. One is to educate people on albinism, on what it is. Secondly, to educate them on how to use the sunscreen. And thirdly, we provide Max, which is a specialized sunscreen that is specialized for persons with albinism. Beyond Suncare is currently in 6 districts, but the plan is to extend the program nationwide. And also the plans are in 3 years, we should be able to compound this sunscreen locally. The other organization that helps us is Tumaini. From a long time, we do Albinism Awareness Day every year in different districts. On this day, we give health education to persons with albinism. Sunscreens, hats, and sunglasses are provided. We also do a clinic where we offer cryotherapy, and if there are any tumors, we refer them to the central hospitals. At Kamo Central Hospital, we do a clinic every Thursday for persons with albinism. Tumaini has actually just introduced transport refund to persons with albinism and their guardians who are coming to attend the clinic. So they are really motivated to bring even their children for a skin check. So this is very motivating that Tumaini has done. The other thing that we've done at Tumaini is to educate primary school teachers on albinism so that they can be teaching it to their students. And also, if they do have children affected with albinism in their school, they should be able to refer them when they have actually skin conditions. When there are persons who just need palliative care, Tumaini has been able to at least support these people financially. The last organization which supports us is Standing Voice. This is a non-governmental organization based in the UK, Tanzania, as well as here in Malawi. It's currently doing its projects in 4 districts. And the main focus of Standing Voice is skin cancer prevention. So basically, health education is given to the ones that are affected with albinism. There are trainings that are given to both DVOs as well as dermatologists and also clinical officers so that they can be able to do these clinics. Outreach clinics are done where we examine persons with albinism in different districts. And then surgeries are done there, right there at the district, where both dermatologists, surgeons, as well as plastic surgeons come to do the operations. And then where there's need, these people are referred to the central hospital. Thank you so much.
What a wonderful presentation. Thank you so much. Really wonderful to see how this is truly working on the ground. Thank you very much for that. What we're going to do is we're going to have one more speaker, and then we're going to have a really nice Q&A break. I know there's like a lot of great questions in the chat, so please keep them coming. I promise we will get to those. So what we'll do is we're going to have one more speaker, and then we will have a Q&A for all of our first group of speakers, just because our next speaker has a little bit of a time pressure, but we're so excited to have her. So that was a truly wonderful talk, and we really appreciate it. And hopefully you can stick around just for a few more minutes for some Q&A after our next speaker. So the next speaker that I would like to introduce is Dr. Mwele Malachela, who is the director of the Department of Control and Neglected Tropical Diseases of the World Health Organization in Geneva in Switzerland. Before her appointment in 2018, she was the director in the office of the WHO Regional Director for Africa in Brazzaville in the Congo, with responsibility for providing policy, managerial, and diplomatic advice. Before joining the WHO, she served as the Director General of the National Institute for Medical Research in Tanzania, and she's the first woman to occupy this post. So truly an honor to have her here with us today. She's worked for 30 years at the National Institute for Medical Research, which she started working at as a junior scientist in the field of lymphatic filariasis, and later working on the immunoepidemiology of filarial infections and running treatment programs. She also holds a BSc from the University of Dar es Salaam and has an MSc and a PhD in parasitology from the London School of Hygiene and Tropical Medicine, where she specialized in filarial immunology, specifically the mechanisms of filarial immune evasion. So it's truly an honor to welcome her today, and we're so happy that you could join us. So I'll hand it over to you.
Good morning, good afternoon, and good evening, everyone, and thank you for the invitation to speak at the GLODERM Autumn Meeting. And I'm here to speak about the WHO NTD 2030 Roadmap and in the context of skin NTDs. So the neglected tropical diseases of the skin, which we normally call skin NTDs, are half of the NTDs that we work on in the department. Some are Buruli ulcer, guinea worm disease, cutaneous leishmaniasis, leprosy, mycetoma, scabies, and many others. And all of them are manifested in the skin. So, as you know, the skin is the human body's largest and most visible organ and easily mirrors many of these manifestations. The skin NTDs are prevalent largely among poor populations and are a leading cause of stigmatization, discrimination, prejudice, and social alienation. And they have been ignored for too long. I've mentioned the 12 NTDs, and here I'd like to speak about their distribution. And they are mainly found in areas, in many low and middle income countries, as you can see from these maps. What is WHO doing? So WHO has developed a skin NTD strategy, but has also embedded skin NTDs into the NTD roadmap, which I'll talk about a little bit later. We've maintained strong advocacy and a robust foothold and buy-in from countries, stakeholders, and partners. We've organized several multidimensional technical and advocacy meetings over the past 3 years to firmly push this very important agenda. What has been achieved? So we have the development of the Skin NTDs mobile application to stimulate dissemination of information, make WHO training guide more accessible, and gather information on its usage and impact, as also to build an interactive platform. It's also helpful in implementation of surveillance and mapping in countries. And it's now, like I said earlier, an inclusion of, with a firm target in the new roadmap. So as you can see with the Skin NTD app, we start with locations, we look at signs and symptoms, and then through those signs and symptoms linked to pictures, we get a close to accurate diagnosis of what the health worker is dealing with. In future, we intend to link this to AI to have better imaging and a better outcome in terms of what the diagnosis actually is. So I'd like to quickly now move on to the roadmap. And the roadmap is a high-level strategy that will set the overall direction for the fight against NTDs for the next 10 years. It's also a tool that will align efforts across stakeholder groups for the next decade. And it was created through a very consultative approach with various feedback from stakeholder groups, including countries, donors, partners, and experts. The roadmap has specific and measurable targets, and we will be looking to these targets throughout the period to 2030, making sure that we are on track to deliver those targets. The roadmap focuses on cross-cutting approaches, so beyond health, looking at NTDs beyond health, so that we can reduce the impact of these diseases. We know for sure that there are several other multifaceted issues, for example, water and sanitation, the human-animal health interface, education, nutrition, that have an impact on NTDs, and it would be important to consider them in the roadmap, and that is what we have done. The roadmap focuses on 3 essential shifts. So first of all, from measuring progress to measuring impact, from vertical programming to holistic cross-cutting approaches, and from partner support and funding to country ownership and domestic financing. What do we want to achieve? We have overarching targets, which are linked to the SDGs, particularly the one on 90% fewer people requiring interventions against NTDs by 2030. We have targets that on 100 countries to have eliminated at least 1 NTD and 2 NTDs eradicated. We have cross-cutting targets, which look at broader issues. For example, issues around basic water supply and vector-borne diseases. And then we have disease-specific targets, which go into a lot of detail, disease by disease. How can then this be achieved? How can the roadmap vision be achieved? First of all, by accelerating programmatic actions. And this is through technical progress, so improving scientific understanding, improving our interventions, improving strategy and service delivery to accelerate programmatic actions, and then a focus on enablers, for example, advocacy, fundraising, collaboration, and multi-sectoral action. It also implies that we have to intensify cross-cutting approaches. So we have to think about integrating NTDs on common delivery platforms, and Skin NTDs is one such platform that combines and works on several diseases. We also have to talk about mainstreaming within the health system to improve the quality of NTD management in the context of universal health coverage. And then we have to coordinate with other sectors, like I said earlier, within and beyond health on NTD-related interventions. And finally, it's the issue of country ownership. So we need to change our operating model and culture to facilitate country ownership. And this is country ownership at national and subnational levels, ensuring clear stakeholder roles as who's doing what, particularly at the country level, and ensuring that our organizational setups actually do push for country ownership, and the organizational setups, the operational models, and our thinking has to be aligned for this country ownership to achieve the 2030 targets. How can we look at these integrated approaches in practice with an example of Skin NTDs? So areas where integrated approaches to Skin NTDs are applicable is in epidemiological surveillance, training and capacity building, which was mentioned a lot during the webinar we had in the last few days on Skin NTDs, promotion of implementation and research innovations, social mobilization and community health education, management and care of Skin NTDs, and integrated planning, monitoring, and evaluation. And the benefits are the greater ownership by national programs, cost effectiveness and efficient use of resources, extended coverage and earlier case detection, which is extremely important, particularly for Skin NTDs, and a greater capacity of health workers to properly manage cases. So how can you, as the Skin NTD community, help to reach the 2030 targets? How can we together get to the 2030 targets? What do we need to do? So support WHO and partners to, first of all, expand awareness, to motivate control and research activities, focus on reporting of skin NTDs to enhance surveillance, and using tools such as teledermatology to support this initiative, to support the development of new technologies, including AI, like I mentioned earlier, to conduct virtual capacity building. Capacity building was a major issue that has been discussed again and again. And I think this is key, that we can use the opportunity, particularly of the times when we're now working virtually, to see how we can use these virtual systems to train frontline health workers. And then to ensure that we advocate for skin NTDs with service organizations, champions, to push this very important agenda forward. I thank you for your passion and dedication to this very, very important work. Thank you for the opportunity to present today.
Thank you so much, Dr. Mwele. That was absolutely wonderful and very inspiring. I think it's so amazing to see this kind of intersection of field and technology and the directions that that's heading. A really, really inspiring talk. Now we'd like to move into our Q&A session. And so if our wonderful speakers from the first half would be willing to turn their videos on, I'm going to turn it over to my colleague Wingfield Remus and Claire Fuller, who will be coordinating the Q&A. And I think we're going to start with Dr. Mwele, only because I know that she has to leave a little bit earlier. And if any of you have questions, please go ahead and do put those questions in the chat. That is how we will be answering questions. We'll be reading those aloud to our speakers. So with that, I'll turn it over to you, Wingfield.
Great, thank you so much, and thank you for the amazing talks this morning. That was really impressive and inspiring. So I know that someone has raised their hand, and if you can put the question into the chat, I will pull that up and be able to ask the question. So I had a couple of questions for Dr. Malachela. I would like to hear a little bit more, if you can tell us about that SkinApp and where it stands in terms of development and the plans for rolling it out. How are you planning to roll it out? Who is the target audience for that?
Thank you very much for the question, Dr. Wingfield. For now, we are in the early development of the so we have like a beta version of the app. The intention is to because first of all it contains the information on the Skin NTD manual. We intend to have for it to be used for health workers, for people who are doing early diagnosis of these skin NTDs. We hope that it can also be used for training and also, of course, you know, as a source of information on the skin NTD work that is being carried out by WHO. So we will. The idea is to. So we're working on it now, and it's in. We can share the link for the app. It's not entirely. You know, it's not totally complete, but I can. You know, I can definitely share the what we have and what we're doing. But then we want it to be used for training, we want it to be used for diagnosis, and we want it to be used for information and knowledge sharing. So we have, you know, a big, we're asking a lot from that app. But then, of course, the other issue is, of course, artificial intelligence, linking it so that we can better get, use the imaging better for better diagnosis. Thank you.
Thank you so much. And you answered one of our other questions, which was how we can help so beautifully. And we really look forward to years of working together with you on in the next 10 years of the NTD projects. It's really quite inspiring work.
I do hope that you will be able to, particularly in the training, because I was very excited about the trainees. And I really think that there's a really great opportunity here of working together and making sure, particularly because now Skin NTD, the profile has raised tremendously, And we really, and half, like I said, half of the NTDs are skin NTDs. We hope that the trainees, this training program will really help feed into the work and support the work that we all need to do to ensure that we meet our 2030 targets.
That's a wonderful point, and I think we're so lucky that we recently formed the GLODERM Trainee Committee, and Sidra Khan, who's our chair of that committee, is joining us today. And it's just a really wonderful group of trainees, residents, and medical students. And so I think that for us is really a core of GLODERM, is that we're really focused on the next generation and building a pathway and a pipeline for folks interested in global health dermatology and particularly in this area. So excited, and maybe Dr. Mwele, we can ask you to do a future talk for one of our trainee symposiums.
Absolutely.
All right, great. We'll hit you up for that. Wonderful. Were there any other questions for Dr. Mwele before she has to leave? If not, I'll pass it back over to Wingfield.
I just wanted to also encourage through Dr. Mwele's excellent, thank you so much for setting that scene, Dr. Mwele, that the Neglected Tropical Diseases NGO network Skin Cross-Cutting Group is collecting a series of tools, of which the WHO app is one of them, and we're critiquing those in order to be able to support this, the roadmap with the right equipment to be able to roll out to countries and give them a framework for developing their dermatological expertise. So we were really, really grateful to be able to share that. And GLODERM, we are a member of that, the NNN. So we are really, really important. So that's how you guys can all feed into that. And so do feel very, very welcome to communicate through us with ideas. And we circulate to you invitations to come to that because your input is so critical and crucial.
Well, thank you very much, Dr. Mwele. It's been an honor to have you on board with us today.
Thank you.
Thank
you.
Thank you so much.
We
did have questions for the trainees. First, to Akash and Dorian with the program in RDTC, do you have a sense of the internet access at some of the distant sites as to whether or not how feasible teledermatology will be at some of those locations?
Hi, thank you so much for your question. I think that's something that Dorian and Dr. Mabura might be better able to answer. But in my experience, the internet access was much better in Tanzania than I expected, and oftentimes
we can try to answer that question. Hello, can I something is wrong with the sound. I can try to answer that question, and I'll say that if I'm with Dr. Mavura, also the principal of the Regional Dermatology Training Center, it will help also to answer that question. But as you saw on the presentation about RDTC, I think it was on the 10th slide, we discussed about, we talked about conditions of people traveling for more than 1,000 kilometers. Unfortunately, we didn't precise the severity and according to the distances, but most of the patients that we see traveling for more than 3 days, 2 to 3 days, coming to RDTC, they are already in a state of superinfection of diseases. They have been treated for a long time.
I think you've unmuted, or you muted yourself, Dorian.
Sorry, I was muted again. So I was saying that we sometimes they travel 2 to 3 days, and when they reach here, they are already in a state of erythroderma, sometimes superinfection. But most of the time, they are these normal dermatosis, not very severe diseases. It's just that after being treated for other conditions, not knowing exactly what is the condition, they come in a status that we can grade as severe. I think Dr. Mavura can add something.
Yeah, I think she's quite right what she has said. What we think also the financial constraint from those patients who are coming quite far it's also contributing to that. As well as the profession of the peripheral who cannot really diagnose the condition, and they give the wrong medication and they mask up the condition, and sometimes it's really becoming worse. Yeah.
Thank you. I had a question for Tuta as well, in terms of follow-up for that patient. Do you, can you tell us some about how things went after the surgeries and whether she has had recurrences of those lesions?
Yeah, thank you for the questions. Yes, after the surgery, their lumps recurred. She have the surgery for about 3 times. But after the surgery, the lumps recurred. But it is before we give her the lipid lowering agents. After the lipid lowering agents, we haven't done any surgery.
Great, thank you. Amazing cases and amazing presentations. Thank you very much for that. For Dr. Barhagotsia, question about funding and about partnership with the private sector. How has that worked for you?
Funding, we get funds from different sources. Sometimes we get governmental funding. We can also get private funding in, let's say, tiny campaigns. We can do it on social networks. Sometimes we present the project to different institutions in Spain or even international ones, and this way we get our funds. We also have the option of becoming a member or a friend of our NGO. That's another way of periodically, like every month, supporting our projects. And yeah, the relationship with the private sector, I guess the question is regarding the private sector here in Spain, I mean in Europe. We have different types of collaboration which we've recently started. For example, there's a brand called 5.5. They produce cosmetics, and they just launched several months ago a specific, which is, I mean, quite nice quality, and the texture is nice. And the collaboration, the partnership is so that for every container they sell, they donate €1 to Beyond Suncare. So many types of collaboration, but some examples.
Great, thank you. And
so would you mind, Dr. just putting in the chat function the web address of the Beyond Suncare, just so people could access it if they wanted to? Thanks. Sorry, we feel like I cut you off.
Oh, no, I was just going to ask, I think there are a lot of people who would be interested, especially trainees, in knowing how it has worked for you in terms of your balance in getting the time to participate in this. Is it something you've done on the side, or have you been able to pull it into your work? How has that worked practically in your life?
Sorry, I'm afraid I couldn't hear part of your question. Could you please repeat it for me? The
yes,
connection something.
For you in your career development, how has participating in this work fit?
A great experience. I mean, as let's say, as a training for myself, dealing with such big tumors and complicated cases, of course, it's interesting. That's for the academic point of view, but then from the human point of view, it's very regarding you get to know what's happening in other countries. You get to see the difference with the problems we have here and the real problems that are happening in some places where it's interesting to get to know so different ways of life. How such, for me, for example, it was very surprising to learn dealing with this albinism issue. I started in contact, I got in contact with albinism in Africa. I have never seen an albino patient in Spain, never before. So when I learned that albinism is always related to skin cancer, and that skin cancer is really a very important part of this condition. And afterwards, I got in contact with the albino community in Spain, and I noticed that they didn't have any problem with skin cancer at all, because they have like as many sunscreens as they wanted, as many long sleeve clothes as they wanted, even if we have quite a nice sunshine here in Spain. But they didn't have, I mean, this was not a problem. The problem for people with albinism in Spain is how do you say, that they cannot see well, they cannot read well, they cannot, maybe at school they get some problems, but that's not the first issue in Africa. So, I mean, getting this point, the perspective of comparing different aspects of the same condition, it has been very, very, I mean, enriching for my training.
Thank you. And one last question for Dr. Mzumara. You mentioned a number of different partnership organizations that you have been working with. And we would like to know something about how do you integrate working with those different organizations, and has that provided any challenges or particular opportunities for you having multiple partners?
Thank you very much for that question. I think it has provided lots of privileges for me. Of course, it's been challenging. As you already know, we are 2 dermatologists in the country, but there was a great need for persons with albinism in Malawi. In the beginning, we were actually just getting sunscreen from donors. So people were just donating and leaving them. Maybe when they come to a hotel, even at the central hospital, would go and ask for it in hotels, people who come visiting tourists. So even with just provision of the sunscreen itself, it was a challenge. So just getting these partners in at least 4 years since I've been here, I think it's a great opportunity for persons with albinism in Malawi.
Great. Well, thank you all. What a great Q&A. And I know we're sad that we can't all be in one room, but I feel like in some ways we're actually getting a chance to be together, you know, in a really new and different way. And it's really just a pleasure to hear this conversation. Wonderful. So with that, I'd like to turn it over to our next set of speakers. Oh, I forgot, we're doing a photo. Before we do our next set of speakers, thank you for the reminder. So if everyone can, this is only, I promise this takes like 30 seconds, it's very quick. But if everyone is willing to turn on your video cameras, and I'm gonna, let's see if we can, everyone, if they're willing to turn on your video cameras, and that way we'll be able to see you. And we're going to have, Sidra is going to be doing some photos for us. Sidra, tell us when you are ready.
Yeah, I can start taking some pictures now. So if everybody just smiles. Great, thank you.
She's going through a few pages, so keep smiling.
Yeah, sorry, keep the cheese is going. We got quite a few attendees, so quite a few pages of pictures. All right, thank you.
Goodness, Sidra's the expert at this.
We're getting there. We're getting there. Yeah, that's us. Well done. Thanks, everyone.
Thank you all for being in the photo. We really appreciate it. It's so nice to see everyone's faces from around the world. So next up, I'm really delighted to introduce a team that's going to be talking. So I would like to introduce Alexia Knapp and also Bayan Alabi. And so Alexia is joining us as a dermatologist at the Health Partners Group in St. Paul, Minnesota in the United States, and core faculty at the University of Minnesota Global Medicine Pathway. And in particular for this, she has worked with UMN International Organization for Migration, the UN Migration Agency, training IOM physicians in East Africa regarding skin conditions in US-bound refugees. She's also a telemedicine consultant to MSF and Doctors Without Borders. And for Dr. Alabi is a dermatology registrar and a Wellcome-funded clinical research training fellow. And she has recently completed an MSc in medical education, and her dissertation project was looking at dermatology curriculum for clinicians managing displaced migrants and refugees, so incredibly topical and important. And she's also attended several medical missions in Lebanon and Jordan to support Syrian refugees. And with that, I will pass it over to both of you.
Hello, everyone. Thank you very much to GLODERM for the opportunity to speak, and I'm delighted to have a joint presentation with Bayan, who is going to be sharing some of her work that she's done on this topic. So today we'll be talking about developing a dermatology curriculum for clinicians working in refugee, migrant camps, and also camps for internally displaced persons. There are greater than 70 million displaced persons worldwide, and that number unfortunately continues to grow. And there's been a high prevalence of skin diseases identified in these groups. And so this is a measure that we're taking from the IFD Migrant Health Dermatology Working Group to try to address the need for dermatologic care in these populations. Next slide, please. Dermatologic care in refugee camps is quite limited, unfortunately, at this time. Usually medical care in refugee camps is primarily, you can look at it like a disaster medicine scenario. So they're addressing malnutrition, diarrhea, malaria, outbreaks of communicable diseases, things like measles and cholera. Of course, unfortunately, there's a very high prevalence of gender-based violence and torture. Care is often provided by NGOs, and depending on the setting, it's a different NGO. So for this camp that I had gone to in Tanzania, Nyarugusu refugee camp, medical care is provided by the Tanzanian Red Cross Society. Generally focused on primary care and obstetrics, and then there's very limited diagnostic capabilities in these settings. So sometimes you can get a CBC, but is even trying to find a light microscope or a biopsy, for example, would be nearly impossible to do. In most cases, there's no dermatologist on site, though in some cases there are dermatologists available via telemedicine, for example, through MSF. Next slide, please. Skin diseases amongst refugees can be divided into several categories, including those that might be identified pre-arrival. These would be diseases that might have developed or been acquired in the country of origin, and this would include neglected tropical diseases such as leishmaniasis. Often there's poor access to preventative health care, including immunizations for diseases like measles. There may be cultural practices that may manifest in the skin, as well as previously experienced violence and torture. In transit, diseases can be related to crowded conditions. These would be communicable diseases such as ectoparasites, fungal skin infections, and impetigo. Disorders related to extreme environmental conditions, and then poor access to food and water, including dehydration and scurvy. And then upon resettlement, mass accommodations in refugee camps can predispose people to skin conditions. And even upon resettlement in a third country, there may be barriers to healthcare access and language and cultural barriers as well. Next slide, please. Dermatologic care in refugee camps, often there is a very limited formulary. And so this is something that we have to take into context when we are considering a training program, that we don't want to put TNF-alpha inhibitors as an option for treating psoriasis when it simply will not be available. Looking at this list, I think it makes most of us dermatologists just get palpitations to see that only hydrocortisone 1% cream is often the only corticosteroid that's available. And that's sometimes what you have to work with. And the formulary will depend greatly depending on the NGO or the Ministry of Health, where the refugee camps are located, what materials can be brought in, and so forth. Next slide, please. If you think about the spectrum of dermatologic diseases, especially in the context of a training program, at the bottom of the list, you might think, or at the, I should say bottom of the pyramid, not the bottom of the list, but the low acuity, easy to diagnose and manage disorders, things like impetigo, scabies, tinea, so really something, those conditions that with just a few, a short training program, you'd be able to educate the frontline healthcare workers in terms of how to appropriately manage these with the materials, the medications that are available. So training primary care clinicians could include live trainings various electronic materials and apps, some of which have been brought up in the chat already, the NLR SkinApp and the WHO NTD app, those types of things, both live as well, or both online and offline, as well as hard copy materials. And it's really important that these are tailored to the local context, and Bayan will be talking about that in a moment. And then for the moderate complexity or acuity, there may be some role for training in those. And then for the really complex life-threatening dermatoses, I think it's really hard to compress a 3-year dermatology residency into just a few days. So this is where telemedicine support can be really helpful, especially if it's timely, it's appropriate to the local context, and that there is also an educational component to help for the next time that similar case may be identified. Next slide, please. This is an example of a live training that I did at Nyarugusu refugee camp. I've done this in several settings in East Africa, working with Tanzania Red Cross and doing just a several-hour session just on really kind of the basics of what do you see commonly. One of the wonderful advantages to this setting, of course, is the opportunity to see live cases together and to really have a back and forth exchange. Now with COVID, obviously, this type of travel is difficult, but as we're seeing even today, the amount of really rich exchange that can occur through Zoom and this type of setting. And with this, I'll hand it over to Bayan.
Thank you, Alexia. I hope you can all hear me. So yeah, leading on in terms of the importance of fieldwork, especially in informing educational development and resources. Before last year, I went to Jordan, and this is the team that I worked with, where we went out to manage mostly Syrian refugees. And I took this opportunity as part of my dissertation project, looking at developing a curriculum to ask clinicians who are not dermatologists what they thought it would be important to feature in a dermatology training package to prepare clinicians to be able to manage skin disorders in these populations. So the bar graph on the top right of this slide shows the responses, and based on their experiences, the common things that they were seeing, which fits with a lot of the published literature, are infections, infestations, so the importance of being able to recognize and diagnose and manage fungal infections, scabies, bacterial infections, but also the inflammatory dermatoses, and a lot of the other kind of rarer conditions also featured. But as we said, it's about balancing the breadth of the material, but also how commonly things we encounter and focusing on those. And then I also did a bit of qualitative work and interviewing to ask them, rather than focusing on specific diseases, but kind of holistically what the educational resources should take into account. And something that stood out was recognizing the acuity of any problem that came along and when to seek help, particularly with telemedical facilities and resources that are available. Again, reiterating what Alexia had said about knowing what treatment options are available, often they are very limited, and how to manage in that scenario. And the importance of medical photography. Obviously, there's a lot of ethical considerations to bear in mind, and so we're kind of now moving into a more relying on technology more, so that needs to be really paid attention to as well. Next slide, please. So as part of my dissertation and curriculum, I had used a lot of educational theory to be able to put together, based on the literature review that I did in terms of prevalence of skin diseases, but also the field survey, to try and map out what is important to involve. I'm not going to kind of go into the figures in a lot of detail, but just to kind of demonstrate that it is about like holistic training about addressing things that we commonly see. And other important considerations are listed in the bullet points below. So it's important that we have representative images in the educational materials that reflect all skin tones. Language is important to make sure that for accessibility, that various translations are made available. Again, with management strategies and what's available locally, and also really important is kind of partnering with local teams, and not just a kind of like kind of send something out there without liaising with the people who are going to be using it. So that's something that we wanted to make sure we paid attention to. Next slide, please. So in terms of practical things that we're working on currently, With the IFD Migrant Health Dermatology Working Group, we have had a breakout session earlier this year and talked about various approaches we could take forward. We have been collating a bank of lectures and training materials, and we're also working with Professor Marone, who is an established dermatologist in the field of migrant health, to be able to update these really useful atlases and algorithms that are already published but are a few years out of date, to try and build on that. And I'll pass back over to Alexia to talk about the online course that's already available as well. Thank you.
So we identified that there was a need to have training materials at different levels. And I think I'm running out of time here, so I'm just going to very briefly, this is a course that was developed by Dr. Carrie Wanat and I for the University of Minnesota, which is now a collaboration with WHO. It's a self-paced online course really built for really non-dermatologist MDs. That's the syndrome base and dovetails nicely with some of the work that Dr. Mwele was talking about as well. This will soon be offered at no cost to clinicians in low and middle income countries. So that's just a really important point. We're also translating it into French and Spanish. Next slide, please. This just is kind of an outline of just one of those topics, one of those syndrome, which is itch in the tropics. Next slide, please. And then this just goes through, we tried to incorporate information on bedside diagnostics. So here there's a video, for example, on how to perform a KOH examination, how to interpret that. Next slide, please. So thank you very much again for the opportunity to speak, and happy to answer any questions later on.
That's fantastic. And I think we probably do have 1 minute for questions right now before we move on to the next speaker. Is there a web address you'll be able to put in for people to take a look at your training materials that you developed? Those are really fantastic.
Yes, we can send out, I don't know if I can put it into the chat, but perhaps I can send an email that will have links to the course. And then we're still putting together, we have a Dropbox folder for a number of training materials. Dr. Rod Hay did a wonderful job putting together short presentations and training sheets on about 10 to 12 or so different dermatologic conditions. That is something that would be freely available and modifiable for use depending on the context.
That's great. You know what we can do, Alexia, is we'll be sending a follow-up email for a survey after this webinar, and we can certainly do a follow-up email to the GLODERM listserv with all the wonderful resources. So I'd certainly ask all of our speakers, Alexia, and also certainly our folks with the Suncare project as well, if any links, and also Dr. Mwele's links, we can actually send out as a group for kind of relevant information, because that's really fascinating. I'm sure a lot of people will be interested in accessing those resources. Wingfield, were there any other questions right now for either Alexia or Bayan, or we can also collate more questions as they come in?
No more questions. Yeah.
Perfect. Thanks, Singtab. All right. So I think with that, we'll move on to our next speaker. Thank you so much to both of you. Really, what a fantastic effort. And I think so valued. I can't tell you the number of times people have contacted me and asked for educational resources. So I think this is really amazing resource to be able to point people towards. I think it will be very well loved and well used, I anticipate. So next up, we have Dr. Elena James, and I'm so delighted to introduce her today. She's a medical dermatologist and teledermatologist at the University of Pittsburgh Medical Center. Dr. James earned her undergraduate degree from Yale and her medical degree and PhD in cellular biology at Baylor College of Medicine, and these are all in the United States. She completed her residency training at University of Pennsylvania with a concentration in skin of color. And she's worked with residents, medical students, and undergraduates, and serves as the director of Skin Health Equity and also of Mobile Derm, which is a program to increase access to dermatologic care in local, rural, and global communities. Dr. James strives to improve healthcare disparities and strengthen patient-provider relationships through community partnerships and service learning. And her current partnerships include underserved communities in Pittsburgh, rural Pennsylvania, Honduras, and Malawi. And with that, I'll turn it over to you, Dr. James.
Thank you. Can you hear me okay? Great. Thank you for having me at this meeting. I've learned a lot so far. It's been great presentations. I bring you greetings from the University of Pittsburgh Medical Center. And so I'm going to focus in on a narrow perspective from the United States as a dermatologist and my experience in training and resources in education. And so this talk segues nicely from the previous talk and also is important for trainees, especially trainees receiving medical education in dermatology in the United States and those who are interested in doing global work. Next slide, please. So I'm going to take a step back and talk about race as it pertains to the United States. And there's an understanding that we have to have that it's a social construct that is artificially developed to divide people into distinct groups based on characteristics. And the main one is skin color. And that's where it plays a huge role in dermatology and what we see, what we think when we're dealing with different skin colors. Next slide. And then racism in the United States. Many of you may have heard or read or seen videos of the problems we're dealing with racism that have been, since the conception of the United States and colonization, the horrors with indigenous people here in the United States, and then slavery. And so we deal with racism on an individual scale as well as on a systemic and a structural scale in the United States. And there is unconscious and conscious beliefs and behaviors that basically affect the treatment, the care, the ability to succeed simply based on skin color. And many of you may have been exposed to sort of the visual racism that we're seeing with videos of killing of unarmed people of color related to the justice system. Next slide, please. So I'm going to focus in on visual racism as it pertains to dermatology. And this is a phrase that I refer to is what we're seeing and what we're learning based on skin color and how there are definitely differences based on the way skin presents in different patients. Melanin plays a huge role in what we see and how things look. So that needs to be understood, especially in the training. So their example on the top is the comparison of eczema, where you see red and pink and inflammation. And then in a darker skin patient, it may be subtle with a purple hue and maybe a scale that's gray or sort of white. And then based on what we see, that may influence our treatment. So because the one that has lighter skin is red and is very obvious, that person may receive stronger treatments, whereas the treatment may be tailored differently for someone who has darker skin where you can't appreciate the inflammation that is present. As dermatologists, we make diagnoses based on what we see. So what we see and how we learn it is so very important. And we know that there are disparities in the treatment of brown and Black people simply based on recognizing appropriate diagnosis, delays in diagnosis, and appropriate treatment. Next slide, please. So we wanted to do a systematic search and review of images that are shown both on a societal level, looking at search engines in the United States, Google, Yahoo, Bing, and look at commonly diagnosed skin conditions. So acne, eczema, tinea. And so we did a search and we made a comparison, a color scale of the images that we saw. Next slide, please. And so we used a Macy Martin 10-point color scale, and we separated it into light, representing white skin, medium, 3 through 4, 5, brown skin, and then 6 through 10, dark skin. And we categorized the images based on matching with this color scale. Next slide, please. And so when we looked at the internet searches, this is an example of warts, and you plug in warts, that's your search term, this is what appears. And so this shows you that all of the examples that are present here are of white skin, meaning that white is the standard, the default, the norm. Next slide, please. This is an example of acne. Search engine, you just put in acne, this is what pops up. We found that in order to see skin of color, brown and black skin, you would have to say acne Latinx or acne black skin in order to see people of color. Next slide. So this is the breakdown of looking at all of the diagnoses: light, brown, dark skin, the different search engines, and the summary looking at 750 of these images was that 80% showed white skin, medium skin was about 15%, and then darker skin was 5% or less. Now this is important because this is conditioning, what we learn, what is the norm, how we think about things, what has importance, what has value, and contributes to what we see and what we recognize. Next slide, please. And so we wanted to look specifically at our educational resources, what we're using to learn about dermatology. And so we use major dermatology textbooks. Next slide. So from Andrews, Bologna, Fitzpatrick, Hurwitz, we looked at 7,170 images. Next slide. And again, we see this 80% average in light, medium, and brown was hovering at around 12 to 15%, and then dark skin was very, very low. We looked to see what common diagnoses were associated with brown and black skin images. It was lichen planus, vitiligo, atopic dermatitis, secondary syphilis, and lichenitis. And this study, in comparison to one that was done in 2006, 14 years ago, is pretty much consistent, showing that over a span of 14 years, when this study was done in 2006, there has not been a significant change or increase in skin of color in these textbooks. There have been other studies in 2019 and 2020 that also confirm these findings. Reasoning and discussions have been suggested that darker skin is difficult to photograph, but we know that that's not the case because skin of color books, when I've traveled to global areas, pamphlets, handouts have beautiful displays of skin of color. Limited spaces, again, priority given to white skin as the standard, as the default, and then using a separate, distinct skin of color book, which is great as a supplemental material, but still it should be contained within the mainstream teaching of dermatology. Not that we have to go the extra step of clicking on a skin of color atlas, or that we have to look for a different book to get the information. Next slide. So action steps, things to do. How can we make this better so that people are able to recognize, treat diseases? It's familiar, it's not new, especially if we're coming from the States and we're doing global work, seeing that a large population in under-resourced areas is people who have brown and black skin, and so that we are prepared to diagnose and treat. So the first step is to be aware. And beware, meaning that you are on alert to see if there's differences in who's in a room, who is being represented, who is being trained. In the United States, 4 to 6% of dermatologists are Black and Latinx, in comparison to the population of Black people being about 12%, Latinx being about 18%. So there's that disparity there. Be intentional. Look for problems, look for ways to improve inclusion and diversity in your communities, in your work locally, neighboring areas, as well as globally. Be courageous. And these are tough topics. It's not pointing fingers. It's simply saying we have a problem. We need to make it better. And so speaking up and speaking out against situations where we see race is a deciding factor as to who's present, as to whose voice is heard. Really ask for change and not be satisfied with later, we're getting to it, it's not okay. And then seeking out people with a different perspective, a different outlook, a different experience, because there may be something that we're doing and we think it's fine, it sounds fine, but people are experiencing it in a different manner. So making sure that our meetings, our groups, our discussions are a very rich and diverse group. Next slide, please. Just want to thank everybody for your attention. Happy to answer any questions. Again, bring you greetings with beautiful fall weather from Pittsburgh, Pennsylvania, which is in the western part of the United States, the eastern part, sorry. Okay, thank you.
Wow, what a truly fantastic talk. Thank you so much, Dr. James. And I think also the inspiration to have actionable items is so important for all of us. So I can't tell you how much we appreciate that voice. And I know, Dr. James, you had mentioned you might have to switch to your phone to take questions. So we're going to give Dr. James a couple of seconds. She's going to switch her audio over to her phone so that she can answer any questions. Dr. James, if you want to give us a heads up whenever you can hear. Oh, okay, she switched. Wow, that was really fast. All right, I'll turn over to you, Wingfield, in case there are any questions for Dr. James.
I would say most of the comments in the chat are thanking you for this, bringing up this really, really important topic and the work to highlight how far we still have to go and the importance of the message of that this needs to be mainstream. And it's great that we have the separate information, but it really needs to be part of our mainstream education. One question about the internet searches. Is there anything that we can do to help diversify those images on the internet searches? When we first started GLODERM, we did a lot of time with everyone logging into the GLODERM site to try to move it up in Google. Is there anything like that that we can actionably do to help with the internet problem?
Hold on, Dr. James. Let me see if I can unmute you. Let's see.
Thank you. That's a great question. And we actually did some research about algorithms in search engines and how they generate this information, because we thought at first it was user specific. And so what a user is using over time and searching for becomes more popular, but that is not the case. And so we really need to, and we've reached out to Google and we've reached out to them to understand what is happening to make this the default in so many cases. There's actually a huge field of study of oppression of search algorithms, where if you search, for example, Asian girl or Black girl, a lot of sexualized images come up. So it's an inherent issue with the people who are generating these algorithms to make them connect. So we really need to, this is a structural problem, and getting to these companies who make these search engines and algorithms.
Thank you. We do have another question about the best way to describe. What do you think is the best way to describe skin pigmentation?
Yeah, I think that's a great question. And so we've been really working on with our residents about how to present patients. And so when we present, it's just like size and it's like morphology when we describe skin color. So it's color and what we see, and everybody's a little bit different, but classically in the United States, patients would present, this is a 25-year-old African-American person. And we want to move away from that, because we want to move away from saying a race, because instantly we start to have our biases kick in, and we want to remove that and have people talk about truly skin color. So light brown, medium brown, dark brown, underhue of green, when they're describing the skin itself. So that should be a part of the physical presentation, and not so that we're triggering, oh, this is a Black patient, so I'm thinking of sarcoidosis, I'm thinking of eczema, I'm thinking of these things. That we're being open-minded and letting the skin present itself, and then we think of diagnoses. So getting away from race and simply describing color as it is, as we see it.
Excellent. one last question. Many people of color in the US have challenges getting access to dermatologists because they may be on public insurance. How do we change that?
Yes, that's a great question. And I think there are several answers. I think one answer is that we need to increase recruitment and retention of dermatologists of color. Until we can remedy this problem with racism, we know that race concordant care, where providers who are of color take an interest in care and reaching out, giving back to their communities, feeling a responsibility and have an understanding of skin. So that is one way that we can work pretty quickly to increase that. Dermatologists need to spread out, and we are clumped in urban areas, in well-researched areas. We're having patients drawn towards us. We definitely need to spread out and find areas. I mean, patients will come to us, that's not a problem. But I think even at the academic setting, looking for areas where we can have a satellite office in a primary care office 1 day a week to deliver care in a lower resource setting. At the University of Pittsburgh, we dedicate time to do community service where we volunteer our time with different partnered local underserved areas. And I think that that's an excellent way to train, increase diversity. Relations is going out into someone's community and learning about their community and serving that. So I would encourage local areas to partner with community practices and make that an integral part of dermatology training. Thank you.
Thank you so much, Dr. James. I feel like we should have like another hour for this discussion. It's awesome. I think this is such an important area. Yeah, we're so, thank you so much for sharing your perspective for us. I've definitely learned a lot that I think I can take back to my clinic for sure. So thank you so much for that. In the interest of time, we'll move on to our next section on skin and climate change. But I'm sure hopefully Dr. James can stick around, and if there's any other questions, or you could contact her separately, because I think you've got a really hot topic that everyone really wants to discuss. Next I'd like to introduce our group that's going to be discussing climate change with us today. And the group is Sarah Coates, Johanna Steyrit, and Wenda McGegan and Biale. And unfortunately, Wenda McGegan has run into some countrywide technical difficulties that preclude him from joining us today. And so we'll just be focusing for now on Sarah Coates and Johanna Steyrit, but I wanted you to hear that Dr. Wende was part of this group as well. So Sarah Coates is a dermatologist at University of California, San Francisco, and a current pediatric dermatology fellow at UCSF. And she's a Fogarty International Center Global Health Fellow in the past year, which sent her to the KS, the Kaposi Sarcoma Clinical Research Team in Kampala in Uganda. And we also have Johanna Steyrit, who is an associate professor and consultant in dermatology at the De La Salle Medical Health Sciences Institute. And he is also a clinical director of the Dermatology, Aesthetics, and Laser Center at the De La Salle University of Medical Center. And he's also currently the editor-in-chief of the Journal of the Philippine Dermatologic Society. And with that, I will pass it over to you, Sarah.
Hi, everyone. It's so great to be here with you today. You can hear me okay? Okay. So I'm excited to talk to you about the effects of climate change on vector-borne diseases. Next slide, please. So we don't have a lot of time together, but I want to provide a general framework for how we're thinking about this. And it might make sense to you intuitively that many vector-borne diseases are endemic to certain areas, and that has to do with climate variables. So we know, for example, that malaria thrives in the tropics, and that's because climate variables affect various aspects of vector-borne disease transmission. Temperature, humidity, and rainfall affect the population size of vectors, how frequently they bite, how long it takes for pathogens to incubate inside a vector, and how good a vector is at transmitting disease. But they also affect the population size and behavior of animal reservoirs, as well as humans. And so for these reasons, climate change affects all aspects of vector-borne disease transmission and will affect their epidemiology. Next slide, please. So I'm going to talk about a couple vectors today to illustrate some key points. So the first is the Aedes mosquito species. This is the one that transmits dengue, chikungunya, Zika virus disease, and yellow fever. And as you can see from this global distribution map, this mosquito species loves the tropics. Next slide, please. So I want to point out that the vectorial capacity for this mosquito is actually the highest that it's ever been. And you can see in the figure on the right that over the last several decades, its vectorial capacity has been slowly and steadily increasing. It's important to know that this mosquito is temperature sensitive, that its survival peaks at 24 degrees Celsius, and that its ability to transmit specifically dengue peaks at 29 degrees Celsius. Next slide, please. Another important thing to keep in mind is that this species is different from, for example, the one that transmits malaria, Anopheles, and it predominantly breeds in urbanizing areas like human-made container habitats and peri-domestic areas. And the efforts that we've made to control malaria, which have been substantial, are not adequate for controlling the threat from this mosquito because it bites during the day, so bed nets don't help. It has different breeding sites, and there are, importantly, no virus-specific therapies for the conditions that it transmits. Next slide. This map is an important feature of what we're talking about today with geographic range of these conditions. This is a mosquito habitat as of 2019. And as we move through the next few slides, I want you to keep in mind the areas in blue because your mind will be drawn toward the red. But this shows the number of months per year that mosquitoes can thrive and transmit disease. Next slide. This is 2050 projections if we are to do nothing about climate change. And the next slide is 2080 if we are to do nothing about climate change. And so this just shows this concept of expanding range. Next slide. So indeed, dengue, which is transmitted by this mosquito, is the fastest growing vector-borne disease worldwide. The case counts from dengue have doubled every decade since 1990, and every year about 20,000 people die of dengue fever. This is also one of the only diseases, both infectious and non-infectious, for which global mortality is on the rise, and that's what's being shown here in this figure on the left as a part of a larger figure of mortality data. Next slide. Chikungunya, which is also transmitted by Aedes, is another example of a disease which expanding geographic range. We used to think this was only in the Eastern Hemisphere until 2013 when it started being transmitted in the Caribbean and then in Texas. And then every year there are about 100 to 200 cases in the US, and most of them are from travel except for Florida and Texas. And so a key point is that if you don't know that this is endemic to your area, you might not recognize it. Next slide. One more vector-borne disease that we can talk about today is cutaneous leishmaniasis. So this is, as many of you know, transmitted by a sandfly vector. There are several pathogenic species, and they all present with various forms of non-healing ulcers that can lead to stigmatizing scars. We used to think that we knew that this was endemic to certain areas like Africa, the Middle East, Asia, South America, much of the globe, but not necessarily North America. Next slide, please. You can imagine that if you're a dermatologist and you see these various presentations, you could think about keratoacanthoma, pyoderma gangrenosum, squamous cell carcinoma, and of course, as you see on the right, these really stigmatizing scars can be developed as a result of this infection. Next slide. I just want to call your attention to a study that was done a couple of years ago, which was a 10-year observational study from Texas. And they defined cases of cutaneous leishmaniasis as endemic if there was no travel history outside of the US in the last 10 years. And what was surprising from this study is that 59% of their cases were endemic. All of these were Leishmaniasis mexicana. So none of that is going to kill you. This is just going to stay on your skin. You might not even have that bad of symptoms. But it's important because if you don't know that you're looking for this because you don't know that this is endemic to your area, you might not recognize it, you might not treat it appropriately. And so that's a very important concern. Next slide. We predict that climate change will drive the vector northward continuously over the next several decades. And in the next 30 years, the vector, sandfly vector might extend as far north as southeastern Canada as a result of temperature changes. Next slide, please. So big take-home points. As a result of global warming and more frequent climate change-related extreme weather events, we expect that certain vector-borne diseases will have expanded geographic ranges and affect new populations. And that's why I think that this is one of the greatest public health emergencies of our century. And I'll pass it over to Johannes.
Good afternoon. Thank you very much, Sarah. So today I will talk about climate change and marine dermatological diseases. First of all, I would like to thank GLODERM for the invitation to speak in this autumn session. And next slide, please. I would like to introduce to you the members of the Climate Change Committee of the International Society of Dermatology. So very quickly, Dr. Louise Anderson from Denmark, Dr. Mark Davis and Dr. Sarah Coates from the US, Dr. Wendin Magen Yashinahe, who unfortunately cannot join us today from Ethiopia, and myself, Dr. Johan Dairit from the Philippines. Next slide, please. So we have published several articles in the Journal of the International Society of Dermatology, and these are our mission and objectives. First is to establish correlation between factors affecting climate change and a particular group of skin diseases. Secondly, to encourage dermatologists to take concrete action to combat climate change. And thirdly, is to promote public awareness on developing trends in dermatological conditions related to climate change. Recently, we conducted an online survey among members of the International Society of Dermatology. Next slide, please. And these are our more exciting projects for the year 2020 and 2021. We have finished writing our research paper on climate change, migration, and skin diseases, and has already been recommended for publication. And I'm currently working on climate change and marine dermatological diseases, and some of the inputs I will share to you today. Next slide, please. So climate change definitely affects the marine environment, and we expect a 2 degrees centigrade rise in global temperature by the year 2050. That means we will have lower oxygen levels in the oceans. And this is expected to increase seawater concentration of carbon dioxide and promote further acidification of the ocean. So we expect a decrease in pH by the year 2100. Next slide, please. And these are the potential effects of climate change in marine life. First of all, it will decrease the number of oxygen-dependent organisms. It will also increase organisms which can survive in oxygen-deficient environments. It can affect growth, reproduction, and development of invertebrates. And more recently, we have been more concerned with what is called coral bleaching, which is currently happening in our oceans and seas. Next slide, please. And just to share with you some new insights about blue carbon science, which is actually the sequestration of carbon by seagrass meadows, tidal marshes, and mangrove forests, and is believed to mitigate climate change and promote coastal protection and fisheries enhancement. And this may affect the population of marine organisms as well as the incidence of marine dermatological diseases. This is different from what is called green carbon science, in which carbon is sequestered mainly by forests. Next slide, please. And these are the major ecosystems involved in what is called blue carbon science. So mangrove, forests, tidal marshes, and seagrasses, and seaweeds. Next slide, please. So which marine dermatological conditions are most likely to be affected by climate change? So I've selected a few groups: marine bacterial infections, toxic sponge reactions, sea urchin stings, and jellyfish stings, and SBE or sea baiters eruption. Next slide, please. So for one of the infections, Vibrio vulnificus infections present with cellulitis, hemorrhagic bullae, necrotic eschars, and necrotizing fasciitis. They occur in warm tropical coastal waters, and the incidence definitely peaks after extreme heat waves. However, an antibiotic resistance has already been detected in many countries, and what's considered by the WHO as quite alarming in 2014. Next slide, please. And in 1998, there has been a report of warmer water temperatures in the Gulf of Mexico, Peru, and Alaska, which increased the population of Vibrio vulnificus and Vibrio parahemolyticus. Next slide, please. And in recent years, even in the Philippines, we have seen, which was previously rare, we have been seeing cases of infections caused by the bacteria Shawonella. Next slide, please. So what about toxic sponges? These are considered as the future winners on coral reefs under global climate change because some species have the ability to acclimate and adapt to ocean warming and acidification. The speculated species, the more common ones that we see, especially in tropical countries, have greater cell membrane support features, which contributes to greater tolerance to stress. Next slide, please. And these are some marine sponge reactions. So the spicules can cause minor abrasions, irritant contact dermatitis, presence of vesiculation, bullae, and desquamations. And the patients may also develop systemic reactions from the toxins. Next slide, please. So what about climate change and sea urchins? So it has been studied that at ambient temperatures, fertilization is quite high. At elevated temperatures, which we expect in the future, in the next few years, there will be decreased fertilization by 40%. At higher temperatures, there's impaired embryo development. So at an acidic pH and increased temperature, this would definitely decrease the population of sea urchins. Next slide, please. So these are some of the cutaneous manifestations of sea urchin stings: local reactions, sharp pain, edema, erythema, formation of granulomas, and deep infections such as tenosynovitis, fasciitis, and bursitis. Next slide. So for climate change and jellyfish stings, jellyfish abundance has been observed from 1994 to 2019, and this correlates with rising sea temperatures. Next slide, please. So as the oceans get warmer, jellyfish are causing pain beyond their stings. And with warmer water, it's a dream come true for them. They grow faster, they eat more, they breed more, and they live longer. Next slide, please.
Johannes, we're just going to have it.
And these are just some of the cutaneous manifestations. Next slide. Just one more slide to go. And this is just a publication on the delayed allergic type of dermatitis with the Portuguese manophora. Next slide. Next slide. So what are the potential effects of increased temperature acidification on marine life? So there's increase in marine bacterial infection, there's an expected increase in toxic sponge reactions, decrease in sea urchin stings, and increase in jellyfish stings. Next slide. All right, so we encourage dermatologists to take concrete action to combat climate change and promote public awareness on developing trends in dermatological conditions. So thank you very much for allowing me to speak in this conference. Next slide.
Thank you very much, Johannes. That was really excellent and a very interesting area that I did not know really anything about beforehand. So thank you so much. I learned a lot from both of those talks. For the interest of time, we're going to move on to Dr. Galvan, and then we'll have time at the end for Q&A for all of you as well. So our very last speaker, last but certainly not least, is Dr. Cristina Galvan, and she's a dermatologist, leprologist, master in mindfulness, which I'd like to hear more about, and has worked in the Spanish NHS since 1988 and currently is at Mostoles University Hospital. She's the author of numerous scientific publications, and she's the lead researcher of the COVID skin study and the lecturer at international meetings on tropical dermatology, scabies control programs, and also COVID-19 skin manifestations. And we're delighted to hear from her today with regards to the global pandemic. Thank you very much.
Thank you very much. So we GLODER people are used to speaking about neglected diseases, but today we are going to switch and talk about over-neglected. COVID-19 is a worldwide over-neglected disease affecting all socioeconomic strata, even wealthy individuals, and that's why much more attention has been paid to it than any neglected diseases that unfortunately remain neglected. First slide, please. Skin is also affected by this multi-organic disease. During the pandemic, we tried to investigate, clarify, and categorize these skin manifestations. Although their cause effect is still unclear, each of the 5 patterns described seems to be related to an age group, systemic severity, and COVID-19 clinical phase. In spite of variability and complexity, COVID-19 skin manifestations are an effective tool for guiding the diagnosis, prognosis, clinical phase, and research grounds. And they become essential in contexts where access to health services and diagnostic tests is difficult. Next, please. COVID-19 makes us global, but not entirely. Are we dermatologists global in skin manifestations recognition? COVID-19 cutaneous manifestations are almost exclusively described in patients with lighter skin, and low-income countries are poorly represented. Subsequently, these authors point out that our understanding of skin manifestations is partial, and there is a need for healthcare providers to be able to identify COVID-19 lesions in all skin types and socioeconomic contexts. Next, please. Susceptibility to SARS-CoV-2 in different races is controversial. This study shows significantly higher nasal gene expression of transmembrane protease serine 2 in Black individuals compared to other races ethnicities. Given the essential role of this protease for SARS-CoV-2, they highlight that this finding may contribute to the higher burden among Black individuals. Next, please. Multiple studies show that socially disadvantaged areas, races, and minority groups have suffered much higher incidence, severity, hospitalization, and mortality from COVID-19. Next, please. After adjusting for age, sex, insurance status, comorbidity, neighborhood deprivation, and healthcare setting, no difference in all-cause in hospital mortality between white and Black patients was found, and only poverty was associated with intensive care unit admission. Next, please. These data support that racism, not race, drives inequity across the COVID-19 continuum. I love the title of this article. And I ask myself about these groups with more diagnosis or worse evolutions. Have they had the chance to isolate? Have they had access to health services? Have they attended more collapsed health services than rich people? So apparently, not only has the pandemic revealed inequities, but also exacerbated them. Next, please. Regarding COVID-19 transmission, is it global? Frequent inequalities in disadvantaged areas, populations generate large differences in exposure to contagion. Because social distancing is a privilege. In addition to health workers, there are many other essential jobs with higher social contact, as cleaners, caregivers for dependents, etc. Sadly, in some scenarios, isolation is not possible, and people must choose between dying of hunger or dying of COVID-19. In many African countries and refugee camps, overcrowded household isolation may even enhance transmission. Poor or absent digital access prevent people from remote working. Living in the suburbs implies long commuting on public transport, and because precarious and crowded neighborhood and household, sometimes lacking running water, hinder hygiene measures. Next, please. These are real examples. Here was quarantined a public figure from my home city. Here, a young Malawian girl, even she's a privilege, for studying at a secondary boarding school, sharing room with 20 classmates. Next, please. Besides late access to health services, talking about the epidemic without a mosquito to blame is also mandatory. Minority populations have a disproportionate burden of underlying comorbidities. Diabetes, cardiovascular disease, obesity related to COVID-19 poor outcome. Its prevalence is directly related to social class and neighborhood. This study shows association between socioeconomic status of the area and life expectancy at birth. And the difference can be as impressive as 20 years. Next, please. Is the indirect COVID-19 damage global? The number of people living in extreme poverty has risen by 37 million since COVID-19 hit, and it will rise next year. In the first world, We are immersed in an enormous economic crisis, and we are experiencing a secondary epidemic of dermatitis due to COVID-19 hygiene measures and personal protection equipment. In developing countries, the absence of monthly support income, the reduced access to food, the collapse of economy, and the paralyzation of health and educational programs are killing children due to malnutrition, increasing deaths by immunization preventable diseases, tuberculosis, malaria, AIDS, unattended childbirth, and forcing girls out of school and into child marriages. Next, please. COVID-19 pandemic is a good opportunity for reflection, learning, and improvement. To confront the pandemic, global comprehensive approach from all sectors and domains of knowledge is needed. There are lots of areas to improve that should lead to a long-term improvements. We still ignore so much about COVID-19. For example, why skin manifestations are so varied and complex, but there are some things we do know, like the fact that inequality do harm to both the deprived and the privileged. If increased disease incidence, comorbidities prevalence, and socioeconomic factors explain the disparities in COVID-19 direct and collateral damage, we as dermatologists should focus on trying to preserve and safely restart non-COVID disease control programs according to WHO guidance and empowering local communities to be self-sufficient. Improving connectivity to enable remote supervision and teledermatology support, promoting research at every setting to bring our knowledge on skin manifestation and beyond in the different races and scenarios, and implementing educational activities, making information accessible to everyone and avoiding misinformation. Next one. Thank you very much.
Fantastic. What a fascinating presentation. Thank you so much, Dr. Galvan Casas. It's really wonderful. We do have, I know we're running a tiny bit over, not because of our last speaker, but just because we had so many exciting discussions that we wanted to have. So I did want to take, even though we are a tiny bit over, just to give people the opportunity to have like 2 minutes for questions before we close out the formal section of the presentation. So Wingfield, I'll turn it over to you. I don't know if there are any questions either for our team on climate change or on COVID-19.
I would just like to highlight a couple of things that are from the chat. We have resources for people who are more interested in climate change, both in joining the or being on the listserv for the ERG from the AAD around climate change, and some talks that are coming up with that regard. And that's been listed with some links in the chat. So if you're interested in that, you can follow that up on the chat. And then I just wanted to say how amazing I thought this session went, or this group of speakers, in highlighting the integration of all of these topics that might have seemed like disparate conversations about race, about skin of color, about climate change, about COVID, and yet how linked they all are, and how important the work of global health is right now in trying to really raise these issues up and look at how they're integrated in the connections between them, because there is so much overlap. And I think what's going on in the world right now really has brought that to the front. It's understanding, you know, kind of where we sit on all of these issues together.
Wonderful. Well, a huge thank you to all of our speakers today. You were really incredible. And I'm actually going to do the short wrap up. Claire Fuller had to leave. So I just wanted to say a huge thank you. We heard from 11 different countries today, and I felt like I was sitting in everyone's living room and kitchen, which is just wonderful to see all of you. And a huge thank you to both the ILDS and IFD for handling a lot of the Zoom logistics, and to our wonderful speakers for bearing with us. We're just so appreciative of everyone involved. And I also failed to thank in the very beginning a very special, important person who's Linda Oyashiku, who's a medical student who worked with me, who was really critical in the full founding of GLODERM and created our entire website and our social media presence. So a huge thank you to Linda for all of her tireless work over many years to make GLODERM a reality. I do hope that people will join us at the American Academy of Dermatology. I suspect it's going to, who knows, but I think the GLODERM portion will be virtual. I can say that right now. I don't think we have any interest in exposing everybody. So it does mean that would be truly open to everyone. Doesn't matter if you were not planning on coming to the AAD, we'd still love to see you virtually. That will be in March. And we do have a number of really great trainee talks. And I have to say, as faculty, like these are in theory aimed at trainees, but I learned a ton from going to them. So don't feel that you have to be a trainee to attend. They're fantastic. And Sidra Khan put in the chat the dates for our next two GLODERM events. We have one on November 15th about pemphigus vulgaris and one on the 13th of December with our team from Tanzania and the RDTC to talk about albinism, which would be great since we heard a little bit about that today. So those are our upcoming events.